Today we'll be talking about obstructive jaundice or surgical jaundice as it's called. I will be talking basically on a guide to the clerking of these patients with obstructive jaundice. Jaundice is a yellow discoloration of the skin, the whites of the eyes, namely the conjunctiva and sclera, and the mucous membranes, especially of the oral cavity. It's due to raised blood bilirubin levels, which is a pigment color orange and yellow. The normal level of bilirubin in the blood is 5.1 to 17.0 millimoles per liter. Of this total bilirubin, the direct bilirubin contributes about 1.2, 1.7 to 5.1 millimoles per liter. The indirect bilirubin is the total bilirubin level minus the direct bilirubin level. Now let's refresh ourselves on this anatomy of the bile ducts, the intrahepatic and extrahepatic ducts. The intrahepatic ducts form the right and left hepatic ducts, which form the common hepatic duct, which then continues to form the common bile duct, which is at the lower end joined by the pancreatic duct to form the ampulla of water, which then joins the duodenum with the second part of the duodenum. Now let's see what happens when there's an obstruction at the lower end of the bile duct here. Okay, most common cause being the stool. Okay, when there is obstruction there, the proximal ducts get dilated. Then there's stasis of bile leading to infection. There's also jaundice of the obstructive type due to the high level of bile that is accumulated in the stomach, in the liver, and it refluxes into the circulation. The bile destined for digestion in the duodenum cannot reach the duodenum. Therefore, there is some degree of malabsorption, and long-standing obstruction can lead to liver failure and cirrhosis. Now let's go through the bilirubin metabolism and to understand what happens when the bile ducts are blocked. In the prehepatic phase, unconjugated bilirubin is formed from the hemolysis of RBC, mainly in the spleen. This unconjugated bilirubin goes into the liver where it is conjugated, and this is the intrahepatic phase. The conjugated bilirubin is subsequently excreted into the bile ducts, which carry it to the small intestine. And in the small intestine, it is converted to urobilinogen and stercobilinogen, which gives the normal brown color of the stools. Now let's see what happens when the bile ducts are obstructed. When the bile ducts are obstructed, the drainage or the flow of bilirubin into the intestine is blocked. As a result, there is lack of conjugated bilirubin in the intestine. Thereby, stercobilinogen is not produced. As a result of this blockage, the next stage is there is an increased concentration of backflow and pressure increases due to the congestion of the liver with conjugated bilirubin, which then diffuse back into the circulatory system. And the high level of conjugated bilirubin in the circulation results in the staining of the various tissues by the bilirubin. And so the patient becomes jaundiced due to hyperbilirubinemia. Some of the urobilinogen in the blood is then excreted by the kidneys into the urine, which gives the urine a dark color, and this is due to the presence of hyperbilirubinuria. The stools, on the other hand, are also affected because there's no stercobilinogen, so the stools become acholic and pale in color. So in summary, obstructive jaundice, there is jaundice which is due to hyperbilirubinemia, conjugated bilirubinemia. There's dark urine which is due to hyperbilirubinuria, and pale stools due to lack of stercobilinogen. Therefore, in obstructive jaundice, the post-hepatic type ducts are blocked and bilirubin is conjugated, which is markedly elevated. There's increase in conjugated bilirubin in the liver and the blood. It results in jaundice. There's increase in conjugated bilirubin in the urine, results in a dark urine, which is known as hyperbilirubinemia. There's decrease or absence stercobilinogen, resulting in pale stools or acholic stools as they are called. The other two types of jaundice, the prehepatic, which is basically an increase in hemolysis of the RBC, the marked increase in unconjugated bilirubin and urine urobilinogen is a significant sign, and the intrahepatic type, both conjugated and unconjugated are elevated, such as in cirrhosis of the liver. We come to a simple classification of jaundice in order for you to help you to clerk the patient, get the history. You have to have some form of classification of jaundice. Okay, jaundice occurs when the normal bilirubin is increased above 1.0 milligrams per cent. It can be prehepatic, as I said, hepatic or post-hepatic. Prehepatic, overproduction of bilirubin due to excessive hemolysis. Intrahepatic is impaired hepatic function. This is also known as hepatitic jaundice, where the hepatocellular function there's dysfunction in handling the bilirubin metabolism. The third one is the post-hepatic or the obstructive type of jaundice, which is due to either intrahepatic cholestasis or extrahepatic obstruction, which is known as surgical jaundice. Okay, these are the common causes of jaundice. Increased bilirubin production, hemolytic jaundice. It is also known as unconjugated hyperbilirubinemia. Impaired bilirubin excretion. These are the hepatocellular or intrahepatic causes. Can be congenital or hepatocellular causes. And these are the common causes. In surgery, most of the time it is extrahepatic cholestasis that we are handling in surgical patients. And these are usually, most of the time, is due to gallstones or cancer of the pancreas, cholangiocarcinoma, and periampullary carcinoma. And these tumors or these causes can be described in painful and painless jaundice. Okay, this is the slide to show you, the simplified slide to show you the cause of obstructive jaundice. Can be intraluminal, and among them the most common is the common bile duct stones. Okay, 70 to 80, in fact nearly 80% of the case causes are due to common bile duct stone, known as choledocholitis. Then among the transmural causes, the cholangiocarcinoma and strictures are the important causes. And extramural, or from pressure from outside, is due to carcinoma head of the pancreas and periampullary tumors. Others include lymphadenopathy causing obstruction, Mirizi syndrome, and surgical accidents, surgical complications, accidental ligation of CBD. Okay, this is the diagram showing you the presence of stones in the CBD and the common ducts, which are the most common cause of obstruction of the CBD. Strictures can be either, the obstruction can be either benign, the most common is choledocholitis and strictures, or due to cancer, the so-called triple carcinoma of obstructive jaundice, which include carcinoma head of the pancreas, cholangiocarcinoma, and periampullary carcinoma. This table here shows you the prehepatic causes, hemolytic causes, types of jaundice, the hepatic causes, usually due to cirrhosis or other causes of drug-induced viral hepatitis, cirrhosis, Okay, these are all tumors of the liver. These are all hepatic causes, intrahepatic obstruction. And in surgery, the most common is the post-hepatic causes, which can be due to gallstones, the most important, the carcinomas which I've mentioned, and also strictures. Okay, this slide summarizes the cause of obstructive jaundice. First, as I said, most common is choledocholithiasis or CBD stones. Second, bile duct strictures, acute pancreatitis, and malignancy. Especially, I told you, the triple malignancy: carcinoma of the pancreas, cholangiocarcinoma, and ampullary carcinoma. The others mentioned here, inflammatory causes, congenital causes, and medical causes, are less important in surgery. What are the history or the presenting symptoms of these patients with obstructive jaundice? Okay, pain. If it's due to stone, most common is pain, and the pain is usually in the right upper quadrant. There can be jaundice, yellow discoloration of the skin, mucous membrane, and sclera. Dark urine, as I said, due to the presence of conjugated bilirubin in excess in the urine. Pale stools due to lack of stercobilinogen in stools. Patient can have pallor due to hemolytic jaundice. Itchiness due to obstructive jaundice. Deposition of bile acids or bile salts under the skin. Fever if there's secondary infection of these bile ducts leading to chills and rigors. And loss of weight in patients with, which are very significant in patients with cholangiocarcinoma, C-head of pancreas, or periampullary tumors. Okay, what are the physical signs that you can get in these patients? Jaundice, as I said, very important. Scratch marks, especially over the arms, forearms, chest, and abdomen. Patient may be emaciated and cachectic if their malignant condition is causing the obstruction. Easy bruising under the skin because of lack of vitamin K being absorbed due to the obstructive jaundice. Hepatomegaly, splenomegaly, and another important finding is gallbladder enlargement. Okay, gallbladder enlargement, especially in obstructions, jaundice due to cancers. Okay, in this respect, I have to remind you of the Courvoisier's law. Abdominal masses may be palpable, especially in the epigastric region and the right paraumbilical region, especially cases of pancreatic head tumors that cause obstruction of the and obstructive jaundice. Ascites due to transperitoneal spread of these malignant lesions, and shifting dullness is an important physical sign that you must look for. Edema and rectal examination. Okay, especially you may be able to get some pale stools on your examining finger.
Okay, these are images to show you what jaundice is. Okay, this is a patient. You can see the sclera is yellow, both sides, and this is mild to moderate jaundice. This is a very severe jaundice where the whole face and the body is stained yellow. And this is moderate degree of yellow discoloration or jaundice. The most important place to look for jaundice is the sclera of the eyes, the conjunctiva of the eyes, especially the under the upper eyelid. Ask the patient to you look downwards and you pull the upper eyelids away upwards, then you see the whole jaundice. The sclera becomes yellow in color. This is a serum of the patient, which becomes yellow on standing, and this is a so-called tea-colored urine of jaundice patients.
And you mustn't forget the 4 important eponyms that are associated with obstructive jaundice. Covacious law, which I already mentioned to you in detail, Murphy's sign, Charcot's triad, and Reynolds pentad. These are all, you must be familiar with all these eponyms which are commonly encountered or used in obstructive jaundice. Next, the other important thing is to classify the jaundice according to painful and painless jaundice. Okay, painful jaundice usually related to gallstones obstructing the biliary system, whereas painless jaundice usually refers to non-stone related and usually is associated with malignancy. Okay, causes of painful jaundice include hepatitis, various forms, alcoholic, infective, drug-induced Wilson's disease, biliary colic, okay, very important, pancreatitis, cholecystitis, liver metastasis, and Budd-Chiari syndrome, which is a venous obstruction of the hepatic veins. Having said that, the most common cause of gallstone, of painful jaundice, is gallstone disease, the stone in the CBD, cholelithiasis. This is a case of a gallstone disease involving the common bile duct. You can see here is a complication of obstructing bile duct being obstructed by a stone, okay, in the common bile duct, resulting in dilatation of the proximal ducts and leading to infection known as cholangitis. So acute ascending cholangitis is a clinical syndrome characterized by fever, jaundice, and abdominal pain. That results as a result of stasis and infection of the biliary duct, which is most commonly by a obstructing stone, and it is very commonly gets secondarily bacterial infection in a patient with biliary obstruction. The common symptoms will be Charcot's triad, fever, abdominal pain, and jaundice. And if the condition is severe sepsis, secondary infection with sepsis, then the patient may also have additional two more symptoms: confusion or mental derangement and hypotension, which are known as Reynolds pentad. The treatment is urgent, emergency treatment, broad spectrum antibiotics, biliary urgent or emergency biliary drainage, example using the ERCP procedures. Next we come to the painless jaundice. Painless jaundice these are the common causes. And I said hemolysis, hyperbilirubinemia, pancreatic or biliary malignancy is the most sinister and most important cause that must be always looked for in these patients with painless jaundice. Hepatic cirrhosis, chronic enlargement of the liver, and also drug-related autoimmune cholestasis. Having said that, this malignancy is the most sinister and the most important of the causes of painless jaundice. And these include the triple malignancy of obstructive jaundice, cystic head of pancreas, ampullary carcinoma, and cholangiocarcinoma. Okay, so obstructive jaundice you can classify into painful and painless. Painful, gallstone related, acute onset, usually due to a stone in the CBD, usually complicated by secondary infection known as cholangitis, and they may produce Charcot's or Reynolds triad, Charcot's triad or Reynolds pentad, and clinically on examination there will be jaundice with marked tenderness and guarding in the right upper quadrant, and the gallbladder usually in painful jaundice due to gallstones is not palpable. This is in keeping with Covacious law. On the other hand, painless jaundice, usually the pain is not the main symptom, Although they may, due to congestion of the liver, they may complain of some dull, aching sensation, discomfort. And malignancy is the most common and important cause, triple malignancy, which I mentioned. These tend to be chronic and progressive in nature, may have a palpable mass in the epigastric region. Usually there is significant loss of weight, and evidence of metastasis must be looked for in this patient, especially edema and ascites. Ascites is usually revealed by shifting dullness, which must be carefully elicited with these patients. The liver and gallbladder may be palpable. If the gallbladder is palpable in a jaundice patient, then according to Courvoisier's law, most commonly the condition will be due to malignancy and not a gallstone obstruction. Okay, these are the clinical pointers that you must look for in your patient. Extrahepatic causes, okay, obstructive jaundice, extrahepatic causes, clinical features. You look for previous history of dyspepsia, intermittent pyrexia, rigors, pain, jaundice, Charcot's triad, and examination Murphy's sign. Other causes include chronic pancreatitis, strictures of the bile duct, and iatrogenic causes due to post-operative strictures of the bile ducts or trauma. Parasitic infections is another important cause, which used to be common before, but nowadays is less common, and congenital causes, biliary atresia and choledochosis. As for obstructive jaundice due to malignancy, the triple malignancy, carcinoma, pancreas, ampulla and bile ducts, and also gallbladder carcinoma. The clinical features will be painless, progressive deep jaundice, weight loss, Courvoisier's sign is usually positive, palpable gallbladder, okay, it's a very important sign in malignant cases. So how you go about assessing a patient? First of all, get a good history to confirm jaundice, the onset of the jaundice. Secondly, look for pale stools, dark urine. If these are present in this patient, most of the time it is due to post-hepatic causes, and these are known as surgical jaundice. So once you establish this post-hepatic cause, find out whether there is pain or no pain. If there is pain, the pain is usually colicky, it's caused by fatty food, and also intolerant to such fatty food. Okay, when this happens, then the cause is most of the time is gallstone. If there is no pain, there is weight loss, backache, non-specific symptoms, then think of malignancy as the cause. If there, in this obstructive jaundice, if there is associated fever with chills and rigors, then think of secondary bacterial infection and gram-negative septicemia. These patients need to be admitted for immediate antibiotics as well as decompression of the bile ducts as soon as possible. On the other hand, if these features of obstructive jaundice are not there, not present, then they are known as most of the time prehepatic causes. Okay, and these are usually these are the causes that are due to prehepatic causes, which are most of the time due to medical causes and need to be referred to a physician for further evaluation. Okay, this brings me to the end of today's presentation on the guide to clerking a patient with obstructive jaundice. In summary, obstructive jaundice is caused by obstruction of the bile ducts, and the most important cause is gallstone obstruction, followed by strictures and tumors. These are relatively common and may lead to grave consequences if there's delay in diagnosis and treatment. Symptoms and signs are quite straightforward and easily elicited if you bother to understand its pathophysiology, as I outlined in the earlier slides. Always remember and keep in mind the common causes of obstructive jaundice when you quiz and examine the patient with obstructive jaundice. For further information on obstructive jaundice, please visit this YouTube channel at this link given below. Thank you. See you again.